And we've got, my understanding is we have over 200 people actually signed up to participate online. We may not have all of those people still with us, but we've got a large audience online. We've got a good audience here in the room. And at this stage, I'd like to give at least 35 minutes for questions and comments from all of you. So let's move to the audience now. What I should have said earlier too, and I'm sorry I forgot, was that there will be no fire drill today. So if you do hear a fire alarm, please go out this door and out of the building and congregate at Nando's next door, or just around the corner. So with that, I'm going to open the floor to the audience both here and in the room. I think I've got an iPad here, although the screen seems to have gone dark, so I'm not sure. We might need a rebooting. But let's start in the room, and then we can bring in our online audience. Yes. And could you please identify yourself?
Yes. Valentina Yami, London School of Economics. So my question is possibly for Noor. Thank you to everybody for the excellent talk. My question is about coordination. So possibly some topic, I can see you're nodding, so possibly is open to the entire panel. If you have any good lesson or bad lesson of coordination of different stakeholders in humanitarian settings, and how good the coordination can be in the face of leaving the country and transitioning to getting back to the government to be in charge. So the building back better that you were talking about, how this transition is really happening or not, and what difficulties did you encounter?
Thank you. I'm going to take 2 or 3 questions, and then I'll hand back to the panel. Fiona.
Hi, everybody. I'm Fiona Samuels. I'm a researcher here at ODI. Thank you very much for this really interesting panel and presentations, and thanks also very much for putting together this magazine. Wendy, looking forward really to reading it. We also have a piece in there for some of the work that we've been doing here on mental health and psychosocial well-being. I suppose I have a couple of sort of comments which will then lead to some questions, and I think I don't quite know who will answer them, but anybody, maybe. It's really great to hear from Noor about the efforts of the Lebanese government to have this sort of long-term vision, and I know Natalia also mentioned that, and that in a way sort of is a sort of, you know, brings together some of the issues that I want to raise, because some of the work that we do is in humanitarian or fragile contexts, but also in more stable contexts. And I think we see a lot of the issues that you raise in the more stable context, and I'm talking about contexts even such as Vietnam, where, you know, it's middle income, we have a relatively effective health system, yet mental health issues still are sort of pushed, you know, outside, and they're not dealt with. And if they are dealt with, it tends to be a very sort of biomedical approach is used. So that sort of takes me on to my sort of next question. And again, it was great to hear about, you know, the sort of community-based approaches that you mentioned, where you actually have a sort of multi-sectoral team at community level, which I think it sounds fantastic. And also, Natalia, you were talking about sort of, you know, how, you know, one size does not fit all, you know, looking, you know, at different cultures, contexts, geographies, etc. And I suppose the one thing that we were looking at a lot, and also what our piece here writes about, is the effects of social norms on all of this. So it's sort of the social norms in terms of accessing the treatment, you know, what is actually needed. You know, is it just sort of your mental health doctor? And it's great to hear that also what Vitsa, I think, was beginning to talk about, how actually, you know, drivers of mental health or psychosocial distress actually come from a whole range of different backgrounds, including, you know, norms like, you know, child marriage, you know, pulling girls out of schools. So I think, you know, some of our recommendations in a lot of the work that we're doing is, you know, how do we address these kinds of issues in a sort of integrated mental health system, which is also sort of multidisciplinary, which is also dealing with, you know, sort of other sectors. And I think these are sorts of areas that we would like to continue working in. And I think also taking into account, you know, historical processes, geographies, where a country is coming from, sort of although countries like, Vietnam, or we worked in Sri Lanka as well, relatively long histories, but not so recent, of conflict. What does that mean in sort of today in terms of mental health and psychosocial well-being? So I suppose, sorry, I'm talking a lot, but I find it very interesting, and I'm really looking forward to reading everything. But I suppose my questions are, is how can we incorporate more of a sort of social norms times aspects into both, providing care, issues around access, understanding drivers, and then also how can we tailor, we found, even if there was some mental health support services, children, adolescents, they're not taken into account, and there's a whole range of other issues which come into that as well. So sorry, I'll stop now.
Thanks, Fiona. And then, okay, I'm just looking at this side of the room. No? Okay, yes, please.
Hitendra Solanki. I work with Action Against Hunger and just recently had a mindfulness and wellbeing project over the last 3.5 years in Southeast Asia and the UK. One of the aspects that I've been working on is creating an emphasis away from treatment to prevention as well. Obviously a balance, and there's a whole spectrum of balance that we need. And I know you mentioned about promotion and prevention as part of your work. I was just wondering, what are the preventative aspects? It's an area that I'm keen on as well, to stop mental health issues developing to a point where it needs an acute level of treatment. We're using mindfulness as an approach over the last sort of 3.5 years. Again, we talk about evidence base, so we're building up an evidence base on that, and the project's continuing. But I'd be very interested to see how the preventative aspect fits into the whole spectrum of looking at mental health within the sector. So.
Thank you. Let's start with those three. I've got one or two online. I know there's someone else in the room who'd like to ask something, but we'll have another round or two. Noor, would you like to start? And you don't have to respond to everything, but maybe
I think there are some linkages between
Yes.
all three questions, so I'll respond
Good.
in one go. So for the first question, which was around coordination, so you've asked about good lessons related to coordination, and then about how do we ensure transition from humanitarian and development. So in terms of lessons, I think that we have three key ones that we could share from the Lebanon experience, and that I've touched upon a bit in what I've shared before. First of all is the importance of having a national roadmap that can guide the response and coordination of the sector. So for us, having the national strategy was critical to guide efforts of all actors and to ensure that efforts complement actually into building the national system and tackling the priorities in the country. And what's key in building this roadmap is to ensure that the process that leads to it is participatory and inclusive of all stakeholders and actors, to ensure that there is consensus and then promote more effective implementation later on. A second lesson is the importance of having clear terms of reference and membership criteria for the mechanism of coordination that would promote increased commitment and engagement of actors to work and to support the coordination mechanism in ensuring all of its functions. As a third lesson learned is the importance of having normative guidelines and contextualized documents and standards that could provide the basis of accountability mechanisms that are quality-led, and that can ensure that interventions that are implemented have a minimum level of evidence required and ensure that we reach the outcomes that we would like to reach. In terms of transition from humanitarian to development, what is critical is to ensure that actors are guided, follow an approach that's based on systems thinking and systems strengthening. Why am I saying that? Because as I mentioned before, emergencies are opportunities to build better system for everyone, as highlighted by the World Health Organization in its Building Back Better report. And also because systems integration is critical to ensure the sustainability of our responses and to address actually the challenge that was mentioned earlier of scaling up. But this entails, in terms of transition, recognizing that humanitarian response strategies are actually have to be integrated within national development strategies. Because not doing so would actually hinder sustainable solutions and would push towards a continued reliance on humanitarian assistance, especially in context of protracted crisis. And here what's important actually to advocate for, I think, is to for example, integrate within the indicators in the humanitarian system that especially donors require some components of system strengthening, so that humanitarian actors within countries can support countries in building back better systems and ensuring sustainable responses on the long term. And also here, I would like to stress on another key component, which is the importance of building the institutional capacity of governance to take on a leadership role in response strategies, because this is critical in promoting these synergies between humanitarian relief, that's short-term, and long-term development. And this could be through the form of strengthening institutional building of governments and strengthening their governance role, because governance is key. And this is actually highlighted by the UN General Assembly Resolution 46/182, which is around coordination of humanitarian emergencies, and which emphasizes the leadership role that governments should take on and the support that should be given by humanitarian actors to governments in that. For the second question, which was around how do we incorporate social norms aspects, and how do we tailor responses to the needs of different groups. For us, and this is also, I will link it to the answer to the third question, which is what are the preventive aspects. So a key direction that we're adopting through the national mental health strategy is to integrate mental health in other sectors. So we're currently, for example, developing joint action plans with the Ministries of Education and Social Affairs to ensure integration of evidence-based preventive interventions at the level of schools, such as life skills and social emotional learning, and to integrate also mental health prevention and promotion at the level of social protection programming that address the needs of different groups, such as survivors of SGBV or juveniles and so on. We're also doing that at the humanitarian level through integrating mental health in the strategies of other sectors within the cluster humanitarian system, such as the sector for child protection or sexual and gender-based violence. In terms of prevention as well, we are working on developing interventions to raise awareness around mental health, because in Lebanon, as everywhere, there's high stigma around mental health. So we do annual awareness campaigns to raise awareness around that. And we're also working around suicide prevention, particularly through building a national framework for prevention and monitoring. And we recently launched, in collaboration with our partner, a local NGO, the first national suicide hotline for the prevention of suicide.
Thank you very much, Noor. I'm going to turn to Alison now. Do you have anything that you would like to?
I just wanted to add. We know from figures at the World Health Organization that dedicated health budgets to mental health is very minimal, somewhere around 1% of an overall health budget. It's very tiny. It varies from place to place. And of that tiny amount that people dedicate to mental health, the vast majority of it is still going to institutional care. So the need for this tertiary level institutional care of psychiatric approaches to mental health is something that we still need to advocate, to say that we need a broader system that comes further into the community. And that's important for humanitarian responses, who also have a high reliance on tertiary care still without that community focus, but it is also in developing contexts. I would also suggest it's also in some high-income country contexts as well, because we know even high-income countries don't have enough budget allocated to mental health. I know that's the case in the UK, in Australia, in America. So it is just so much more pronounced in low resource settings, and it becomes so much more difficult in humanitarian settings, because then you're dealing with health systems that have broken down. So I would just say that gap in care, that need for increased budget, and that reduction in institutional medical model types of care, we need to continuously have a joint voice to advocate around that. And one of the ways that you can advocate it, as Lebanon has done, is to look at integrating it in a more community-based strategy. So many countries still do not even have a mental health strategy. And many countries do not see mental health or psychosocial support for prevention and promotion and early identification in other areas such as education, protection, violence and so forth. So there are actually other ways outside of health that we can be promoting that as well.
Thank you. I understand Vitse is on the telephone. Is that right now?
Yeah, that's right. I hope you can hear me.
Yes, we can hear you now. I'm so sorry that we couldn't hear you in the other connection. But Vitse, I wondered if you wanted to come back on any of the... Did you hear the questions that were asked?
Yeah, I did. And I'm very glad that there's so much interest in the room for prevention and promotion approaches and approaches to mental health that move beyond treatment in the health sector. I think that's absolutely critical. And I think Noor gave some really good examples of how you can achieve that. What we have seen is a major challenge, is that the different stakeholders don't work well together, because they get funding from different types of donors in the health and the protection sectors. They build up their own mandates, they build up their own kind of logic and rationales. And it's really difficult even within one humanitarian organization to get different sectors to work together well. But what we've seen is that it's easier to do that once everybody sits at the table in the beginning of a project. When you can bring, I don't think it's only important to bring back the different agencies together or departments within one agency. It's also really critical to work very closely together with the affected population. Because for the affected population, when you start talking about problems, often the integrated nature of the problems immediately becomes apparent. And when you can bring that voice to the table, I think it's much easier to advocate to kind of our fragmented health humanitarian actors that it's critical to address multiple problems at the same time. And what we often do is we go in in assessments with open-ended questions, asking people about their priority problems, but also asking them about the causes of those problems. And that information we can bring to, for example, a women's protection unit in a humanitarian agency, as well as a mental health unit in an agency, and say, hey, look, what people are telling us is that domestic violence is the main reason for maternal depression, for example, and it seems that domestic violence is critically linked to alcohol abuse by spouses, and we need to address these problems all at the same time because they're all related. If you only address one, the other will continue. How can we do this? What would be the theory of change behind the program? And so to work together through the logic of a project and not to kind of impose that from the outside, if that makes sense.
Thank you for that. Yes, and the article I mentioned earlier that by Courtney and Leah, one of the approaches that they take in their work, and perhaps this is something that you do as well, is the sort of co-creation of the program, working together directly with affected people on some of those elements. Natalia, I wanted to move to you now. I hope you're still with us. And before you respond to those questions, I also just wanted to give you one more, which I have from the online audience, which is directed specifically at you. So I hope that's okay. And this person says, Natalia, it's Ashley Ashley, it looks like Michelle Namiro. Natalia, thank you so much for sharing about your work in CAR. You mentioned that the clinical psychology works with the GPs, and in the first month, the GPs shadow the clinical psychologists. can you speak about how you navigate their time shadowing and their time seeing patients in the outpatient clinic?
Absolutely, and thank you very much for this question. I would like to clarify that the way that we set up this program is through integration of mental health into primary care services, as well as in other services we provide. So having this shadowing experience doesn't mean that we take out the GPs from the services which they would have been providing otherwise. Instead, what we do is actually bring our clinical specialist into the OTP services that are being provided, and having him, this is a he in our situation, but having our clinical specialist provide the consultations as a part of the OTP. And so the GPs that are there, normally they are doctors or nurses, they're still present and able to provide their consultations as they would have. The specialist is present, and together, if one of their patients that they see through the OTP is a person who requires MHPSS services, then together in the same space, in the same clinic, they will be providing services. So this is not a parallel structure where we have mental care clinic that is separate, but this is actually services that are provided at the OTP services. So it does not interfere with the GP's other responsibilities, but it builds upon the services that they already provide to integrate mental health into the services provided. So there really is not much of the competition. And in fact, I should note that integrating this kind of care into their services in long term reduces the burden on the GPs, because they're not going to be seeing the same clients whose underlying issues in mental health are not being addressed. They're able to address the MHPSS issues, and they're also able to treat any other kind of illnesses for which they're being seen at the primary healthcare level. So I don't know, I feel like this is a good opportunity for me also to transition into answering the other three questions, because I wanted to elaborate a little bit more on the coordination question in particular, and to give an idea of how we are navigating that kind of challenge, because coordination can be challenging. It has to be done at so many levels, as all of the panelists have mentioned, at the community level, as well as at the Ministry of Health level, and with other implementing partners, donors, and organizations. So I wanted to explain that the way that we have structured the program is really built around the 6 core areas of the mental health integration. And those 6 core areas have been assembled into a toolkit for integration of mental health in humanitarian settings, which has been the labor of love of our MHPSS team for the last 2 years. They have worked with WHO and with UNHCR to put together a series of guidelines as well as field examples of how to really improve coordination. So all of these 3 steps and the 3 cross-cutting components that are really the key areas of this toolkit address coordination. The first one is to assess and plan for the mental health integration, and that is something that I had briefly mentioned. And the idea of that step is to make sure that we understand the kind of coordination tools coordination systems that already are there, the kind of resources that already exist at the Ministry of Health, at the local level, and to understand the kind of capacity that is there, so that we can build on it and not just create something that will collapse, would be no transition, no exit strategy. This is the capacity of the healthcare workers that are already there. Instead of just bringing in our staff that will provide leave and everything will collapse, we need to build the capacity of these healthcare workers. And when we mention healthcare workers, this also means community-based healthcare workers. This means also community volunteers. This means larger systems that exist within the society, so that we can provide those kind of social services as well, and we can address the kind of social norms that the second question had brought up. The third would be to strengthen the actual health systems. And this is a crucial part, and first has to be adapted based on the health system that exists. This means actually, oh, sorry. Can you hear me?
You were finished, yes. Yes, if you want to wrap up, because I've
No,
got quite
apologies.
a few. No problem.
Okay.
I thought you were finished. But
Okay.
But I have some other questions which I'm going to ask you to respond to in any case. So let me carry on with those. I know we have at least one more in the room. Oh, we've got several in the room. But I've also got some online. So let me just pose a couple from the online audience and then take one or two in the room. So I've got a question from Chris from the Humanitarian Grand Challenge. And Chris is saying, can we all do more to deliver mental health care to people besieged in the most difficult of war zones? Is anyone doing comprehensive mental health care in Syria and Yemen? Can digital tools improve that? So that's really three questions within one. Well done, Chris. And let me see. I've also got one from Zahra from SOAS and WaterAid. How would you suggest we encourage different cultures to adopt what's been discussed today? Mental health is stigmatized, even in humanitarian crises, and this creates hurdles in recovery. What would you recommend? So those are two rather meaty questions. Now, I'm going to call on some people who haven't asked questions yet, and from this side of the room, because we haven't had any there. Yeah.
Matthias Havon from LSHDM and Global Health Alliance Germany. So the German government is currently in the process of drafting or seeking input for the new global health strategy. And one of the questions would be, what would you see as the priorities for the international donor community or the international research community to support mental health in humanitarian crisis?
Thank you. One more, and I think it's going to have to be this person here who's had her hand up since we started.
Thank you. Lizzie Hobbs from King's College. My questions are also for Noor. There's been quite an extensive survey done by UN Women and ABAD in Lebanon recently that looked at perceptions of masculinity. And they found that there were really high incidences of men identifying with mental health problems, but also they were the least likely to access services. And I just wondered if that was a thing that you also identified in your work. But also, UN surveys have also shown that 75% of Syrian refugees in Lebanon are not legally registered. So I wondered whether these are probably the most vulnerable. There was any way for them to enter into mental health services if they're outside of the legal system.
Thank you. I'm also going to call on Anne for one last, who's just here, Hannah.
Thanks, Wendy. I wanted to ask the panel, but particularly those who are perhaps working at the field level. A lot of the research that we're funding is actually through kind of controlled designs. We're looking at what Alison has called the scalable psychological interventions. And many of those are actually targeting either unskilled or lay providers. And the idea behind doing this is in order to actually meet the needs of the largest possible number of people. But I was wondering what the challenges are when you're trying to develop interventions that will be then facilitated by unskilled providers. What the challenges are in terms of actually having quality interventions when that is actually rolled out at scale. Because it strikes me as once you've got a controlled study and design, it's very easy to keep an eye on what's going well. But actually, once it becomes scaled up, I know Alison sort of inferred this was a challenge, but I'd really be interested to know what kind of solutions we can find in terms of the fidelity of the application of interventions. Thank you.
Okay, I think we'll have to stop there, and that's probably too many questions for everyone to address in our remaining 13 minutes. So if you could, panelists, think about which ones either have been directed to you or that you really want to answer, and we'll see what we can cover in that period. And don't forget that we have, after this session, for those of you in the room, coffee and tea outside, networking, and you can ask further questions of the panelists there. Right, I'm going to start with Alison, actually, this time.
Okay. There's a lot going on here. Is there anything that anyone can do in a humanitarian response to provide psychosocial support? That was always the intention of psychological first aid. So the idea is that anyone from a water and sanitation provider to a local volunteer to a doctor to the local barber to someone distributing food, they could be easily and quickly trained and oriented into psychological first aid And it really is just about some basic do's and don'ts of how to interact with people in distress, so that then we're at least not doing any harm. So is there something everyone can do? I would definitely say yes. Very quickly, we're thinking a lot about technological approaches to reach some remote areas. Yemen and Syria are big on the agenda because the difficulty of getting in and out and getting people in and out. Certainly when I was with World Vision last year, we did some substantial psychological intervention training through online training processes. And the results are probably still out on how successful that's been in relation to quality. Certainly that's the best way to access, but how to actually monitor it, particularly with an unskilled workforce, is a tricky challenge. But it is something we have to keep working on, and everybody needs to keep working on it. This is not something that's going to go away. I'd just like to relate to the challenges of unskilled or non-specialist providers providing psychological interventions. One of the areas that World Health Organization is looking out for now, and it's a key area of my focus now, is to look at what are some of the basic competencies that people need to be able to pass, for want of a better word, to deliver psychological interventions, so that we know that we are actually putting out into the community workforce people of quality and people who meet certain skills standards. The other aspect to that competency work that we're trying to develop and evolve more is how we look at assessing competency and using that to continuously improve people's skills and improve programs. So are there ways that you can do continuous competence assessment every number of months or every, ad hoc moments, so that then you can actually check in on quality and check in on fidelity of the interventions? From an implementation perspective, clinical supervision still continues to be in great demand, but the way to make that sustainable is to ensure that you've got competent supervisors who are local, so that they're not dependent on international experts. And that's something very much on a lot of people's minds, and that's also coming into some of the competency work that we're looking at in WHO, to say, well, okay, it's one thing to have skilled and competent helpers, but we need skilled and competent supervisors and trainers and people that are working alongside them as well, so that the whole system of scale up through a non-professional workforce actually has some quality behind it. I'll leave it there for the moment.
Thank you, Alison. Noor.
Okay, so I'll try to touch upon questions, and if I don't, please let me know during the break.
We'll be a bit brief,
yes,
because we have
very
we
brief.
want to bring in the other two.
So there was a question around how to address stigma around mental health, which is a key challenge. So I mentioned several preventive and promotional interventions that we are implementing, and I would like to add here that there is a very important role for the media in addressing stigma and raising awareness about mental health. In Lebanon, for example, we're currently finalizing a media toolkit around mental health and substance use and suicide to encourage a responsible portrayal and reporting around that and contribute to increased awareness. Regarding the question around what would be the priority to support mental health in humanitarian crisis, and here I would reiterate what I mentioned earlier, which is the importance of systems strengthening and ensuring the merging of humanitarian and development agendas to be able to build national systems that can cater for the needs of all persons, host populations and displaced populations. Regarding the question about men not accessing services, there hadn't been any national mental health information system that would be able to track this data before we started working on the strategy. We're currently building such an information system that would allow us to track service utilization and quality. And we started actually in the beginning of this year collecting MHPSS indicators from humanitarian and non-governmental actors that are providing mental health services, which will allow us to see how services are being utilized, trends in diagnosis, and also the population that is accessing these services. Finally, there was a question around the question around quality, how to ensure quality when you train non-skilled professionals, it's not any recommendation, but in Lebanon, what we are trying to do is that we're capacity building, for example, for non-specialized professionals in primary healthcare on mental health is coupled with support and supervision, ongoing support and supervision within the PHC centers. And we're also building, as I said, the National Mental Health Information System that would have quality and outcome level indicators so that we be able to better monitor service provision.
Thank you, Noor. That was a very comprehensive answer, but very concise. I'm going to move now to our online panelists. Could we start with Vitse, if you're still there?
Yeah.
Yes, please.
I guess the point I would like to pick up on are the question raised about can we do more in very inaccessible areas, and the question about the quality of care when delivered by paraprofessionals, because to me those questions are linked. I think there are areas that are completely inaccessible to even paraprofessionals, or at least to supervisors of paraprofessionals. And I think what came to my mind was that a new intervention that WHO developed may be a good candidate for intervention there. This is a guided self-help intervention that is delivered through audio recordings and a self-help book. Was initially funded by WHO in Syria for the specific purpose of being available in areas where there is no access. We adapted the intervention in northern Uganda with Sudanese refugees. And initially the idea was this may be something that you can drop from a helicopter almost, that you can drop self-help books from a helicopter. We found in northern Uganda that it is not that easy. I guess that may still be an option, but with the South Sudanese refugees, we found that group process is very important, and some more facilitation was found critical. We've done a randomized controlled trial on the intervention and found that it was effective. Running up results at the moment. Research that was also funded by R2HC. And I feel that is an intervention that holds promise, not necessarily because it increases the quality of care delivered by paraprofessionals, but because it actually makes the role of the paraprofessional smaller, because it is an audio recorded intervention. Training is much easier, supervision is much easier, and you know that there will be fidelity to the intervention manual because it was audio recorded. That might be a solution, but kind of the other way from the kinds of other projects that are going on.
That's an interesting example. Natalia, I think you're going to have the last word because we've got just about 4 minutes left. So please do respond to any of the questions that you'd like to, bearing in mind that we don't have much time left. Go ahead, please.
Sure. Thank you. I would like to just briefly touch upon two of the questions. The first in regards to the priorities for donor and the research community. And to that to me, really the priority is making sure that we do have interest in long-term interventions and a much more significant funding. And the long-term interventions that are funded kind of bring me to the next point, which was the question about the role really of non-specialist providers and how can we assure that the quality of the program is there. To me, this is only possible when we have long-term kind of interventions. And I do think that these non-specialists have a very significant role to play. A good portion of people who require MHPSS services do not require medicated care. For that, I do think that we do need to have skilled providers with specialist funds. But for the rest of the clients, there's so much that can be done by non-specialists. So we use traditional birth attendants, there's the community health workers, there's first aid workers, all of whom can be trained on PFA, as Dr. Schaefer has mentioned, and who can be trained on case management without medication. Having those resources available in the peripheral communities really can increase the quality of the access to care. And of course, we do have to make sure quality. In order to do so, we would propose to have a first period of intense supervision, during which we look at documentation of the patients that are being diagnosed. whether the diagnosis is actually concordant with what our specialists can diagnose, and then targeting this non-specialist providers that are making mistakes to make sure that they can actually improve the quality of their diagnosis and of their care. And then after that, subscribing to the suggestion of Dr. Schaefer of bringing them in once in a while to have a refresher training, to do an assessment of their competence, to make sure that they do have the support, the technology, any sort of materials and supplies that they have. And of course, tracking their progress, doing satisfaction interviews, really stepping up the meal components, the monitoring evaluation of seeing the quality of each of our providers. So with that kind of approach in combination with a long-term funding by the donors, I think it is possible to increase the access to the MHPSS services and to really provide care to the vulnerable population. I fit into 4 minutes. Thank you.
Thank you very much, Natalia. Well, we have reached the end of our time now, and I'd really like to thank our panelists for the excellent discussion and raising the issues that we have. I hope that all of you who've come today and who are online will enjoy this edition of the Exchange and find it useful and thought-provoking. And I'd like to thank our very large online audience for joining us too. So thanks to everyone. Please join us if you can outside for more conversation, networking, and a few refreshments. And we look forward to continuing the discussion virtually. Thank you.